from Geneva, and I'm sure you've seen the title of my presentation on program, but today I'll be specifically talking about eye disease visualization. So, intracranial aneurysms. It's a complex disease with lots of options and high stakes. With that in mind, you always feel confident justifying your decisions. After all, when choosing how to treat a patient, the challenge is the interdependencies between the common factors used in clinical decision making. As you can see from this confusion map, with the black cohort with the black squares representing the interdependencies between factors, quite a lot of factors are associated one with another, which means that a change in one can lead to a change in the other one. This limits the univariate analysis we often perform. So, concerning the methods of our study, we enrolled patients diagnosed with a newly discovered intracranial aneurysms at the HUG between January 2007 and December 2023. We then excluded patients with data yet to be structured and patients with fusiform aneurysm. This left us with 1,047 patients we used in the statistical analysis. We also studied patient-related factors with non-modifiable such as age, sex, and family history of IA, and modifiable with smoking status and hypertension. One of our outcomes was also disability at 1 year. We scaled using the MRS. Concerning our aneurysm-related factors, we had location, size, and multiplicity, and a modifiable which was treatment, and lastly, rupture. What do we mean when we talk about probabilistic mapping given specific conditions? In geographic mapping, we can often use Pythagoras' theorem to calculate a distance c by using known A and B measures. In probabilistic mapping, we can similarly use Bayes' theorem, which allows us, by knowing a probability of an event in our full cluster and a probability of in a full cohort, and the probability of a cluster and its conditions, to calculate the probability of an event in this cluster by implementing specific patient characteristics. Now, concerning our results. We firstly compared our cohort to other cohorts references study in intracranial aneurysm by dividing it in ruptured and unruptured parts of our cohort. We compared the ruptured part, with ISAT, and the unruptured part with Ishria, phases, UCAS, and ISDC. There were small but significant differences, for example, in location with ISAT and outcome with ISAT as well. Comparing to Ishria, phases, and UCAS, there were differences in aneurysm size. We had generally smaller aneurysm than these studies, but in general, our cohort was quite similar to these references studies. We then performed a univariate analysis between the influence of factors on patient outcome, which revealed on this forest plot that younger patients, positive family history, multiplicity, low-risk locations, and smaller aneurysms under 5 millimeters were generally associated with an excellent outcome. On the contrary, aneurysm rupture, gigantic aneurysms over 25 millimeters, and interestingly, aneurysm between 5 and 7 millimeters were associated with a poor outcome. Age, while not always significant, there was generally a downward trend as age advanced. On to the highlights of this presentation. Visualizing eye disease. This is a representation of every factor in our cohort and its proportion. We can see, for example, that 43% of our patients are observed, 29 treated surgically, and 28 treated endovascularly. There is also a third of our patients who are ruptured, and 88% have an excellent outcome. Now, Imagine you're in a consultation with a patient and you have this tool in front of you. You're able to choose and select some characteristics that are specific to your patient. For example, you have a female, age 40 to 64 years old, with no family history of FIA. And she's diagnosed with a solitary, unruptured aneurysm located in a high-risk equipoise location. You can see how the other factors have changed. The aspect ratio is a bit generally smaller than in the full cohort. Half of the patients are treated endovascularly, and and a quarter are treated endovascularly, and a quarter microsurgically. The outcome is also excellent, with 84% having an MRS between 0 and 1. Now, let's see what happens if we decide to treat this patient one way or another. For example, endovascular. The characteristics have changed. Aspect ratio is now much higher, with 70% having a high aspect ratio. And, for example, smoking, a lot of the patients have never smoked. The outcome, still 90%. So, an excellent outcome. But, if we choose to treat this patient microsurgically, you can firstly see the outcome is a bit worse, with only 67% of patients having an excellent outcome. But, looking at the other factors of our patients, we can see that a lot of the patients are still current smokers. And the aspect ratio is much lower, which means that these patients were harder to treat endovascularly, thus requiring the microsurgical treatment. What we could also realize by using the Bayes theorem is to calculate and represent the outcome as well as its uncertainty. In our case, with the light green part of the bar, we're able to see the confidence interval and the uncertainty based around the estimation using Bayes theorem. For now, it's still large, but it's due to the low number of patients in our cluster. So, with that in mind, our goal is to create a tool that allows clinicians to visualize and estimate patient outcome given specific patient characteristics by integrating the interaction between the commonly used factors. So thank you everybody. Thank you for specifically Professor Wislinga, who was our mentor and professor doing this work.